We need, as military surgeons, to be prepared to take care of burn patients. We think that about 5 to 10% of casualties on the battlefield will have a component of burns. Often, by the way, in combination with other injuries, which makes military burn and trauma care a little different from civilian care.
Enter the world of military trauma surgery with Frontline Surgery, where we bring you expert insights and real-world scenarios to help surgeons stay ready.
Brought to you by the AAST Military Committee. Join us as we engage in conversations with field experts, examine critical battlefield scenarios, and uncover the strategies that keep surgeons ready for anything.
Stay prepared and stay sharp with Frontline Surgery, where every episode provides key insights into mastering military trauma care.
Welcome to Frontline Surgery, where we focus on preparing surgeons to master military trauma care. I'm Rachel Russo, joined by co-host Jay Yelon.
Hi, I'm Jay Yelon. I am a Navy trauma surgeon and look forward to discussing our topic today.
Today, we'll be honored to welcome Colonel Retired Lee Cancio, the director of the U.S. Army Institute of Surgical Research Burn Center, and one of the world's leading experts in burn care. Dr. Cancio is a board-certified surgeon and intensivist whose distinguished military career spans multiple combat deployments and decades of leadership in burn and critical care. He has helped write the playbook for modern battlefield burn care, and now guides both clinical practice and innovation for the U.S. military burn community. Today, we'll discuss what surgeons need to know about deployed burn care, what's changed, what still applies, and how we prepare for future conflicts where large-scale burn injuries may once again become a common reality.
Dr. Cancio, thank you for joining us today, and we look forward to this great discussion on really a topic for the deploying surgeon that's vitally important. So I wanted you to imagine that you're advising a young surgeon who doesn't typically manage burns. They are now deployed, perhaps with limited resources, and now have to manage, say, a sailor with a 30% total body surface area flame burn. Most general surgeons have minimal formal education on the management of burns, let alone hands-on experience. How would you suggest that the deploying surgeon prepares themselves for managing burns?
Oh, yes. Thank you very much for that introduction and that question. And that scenario is only too real. And the lack of formal training or experience in burn care is definitely going to be a challenge to a deploying surgeon, whether it's during peacetime or more so during wartime. If you're talking about, say, a sailor burned at sea, particularly during conflict, the ability to reach out and access online resources will probably be extremely limited. So therefore, what you take with you may be all that you have access to in terms of resources. If I was preparing to deploy, I would try to take the Advanced Burn Life Support course. If I was deployed and had access to the intranet and I had not had the opportunity to take ABLS in person, I would still try to avail myself of ABLS Now, which is an online version of ABLS, to get that initial emergency care background. But going beyond that, the deployed surgeon really wants to know more than just emergency care. Bear in mind that the ABLS course was designed and intended for physicians working in an emergency department at a referring hospital in the United States with ready access to be able to transfer a patient to a burn center. So the focus is on identifying what patients merit burn center referral or transfer, and then achieving that safely and rapidly. But when we deploy, we have to assume we're not going to be able to do that. So we've got to think about completing the 24 to 48 hour resuscitation period. We have to think about ventilator management. We have to think about wound care and actions to prevent the patient from developing a wound infection. And we have to maintain perfusion to burned extremities. So all of those issues of early post-emergency department burn care are part of what that deployed general surgeon needs to worry about. So if I was taking a single resource, certainly I would want to take the Joint Trauma System CPG on burns. I'd want the whole collection of CPGs, in fact. And also, I would want to take a copy of the Emergency War Surgery Handbook, which is a good guide to the care of burn patients intended for the deployed surgeon.
Thank you very much, Dr. Cancio. I think that was an amazing overview of the types of things that a deployed surgeon is going to need to know about burns. What I want to do is delve a little bit deeper into some of the management principles now. Can you tell us what are the key principles of burn resuscitation in order to avoid under or over resuscitation? Because what I remember is lots of fluids, but what we know then from trauma care is that too much fluids can also be bad, and that when you're talking about a resource-limited environment, carrying around a large volume of pretty heavy IV fluids can be limiting. So as you talk about that initial 24-hour period and transitioning into the prolonged casualty care that may extend up to 72 hours of burn resuscitation, how do you imagine the resuscitation in respect to IV fluids to evolve over time?
Yeah, definitely resuscitation of patients with burn shock is one of the critical gates that we have to get through on our route to getting a survivor. And it is easy, as you say, to either under resuscitate or over resuscitate. Rather than give lots of fluid, we want to give the right amount of fluid, not too much, not too little. And that can be pretty challenging. And it really requires for that patient with burn size greater than 20%, it requires hourly monitoring for at least 24, if not 48 hours. And definitely we use the urine output as the primary index of the adequacy of resuscitation, aiming for a urine output of 30 to 50 cc's per hour in adults, zero point 0.5 to 1 cc per kilogram per hour in children. But beyond that, we also have to bear in mind other indices of adequacy of resuscitation that we would also use in trauma patients, generally, such as the lactate, the arterial base deficit, the patient's blood pressure to some extent, whether or not the patient requires vasopressors to support the blood pressure, peripheral perfusion, and mental status. Beyond that, we really need to pay attention to avoiding over resuscitation. And in order to do that, one of the things that I found helpful is to maintain situational awareness of my cumulative volume infused. If I hit 250 cc's per kilogram at the 24-hour point, my risk of compartment syndromes, especially abdominal compartment syndrome, goes way up. And of course, individuals vary, but 250 cc's or 1/4 of your body weight as fluid resuscitation fluid is a danger zone that we do whatever we can to stay below. So what techniques do we have to try to, moderate the fluid infusion volume? Well, first of all, we maintain that situational awareness. So sometimes it's tempting to give more rather than to give less. So giving too much is just as bad or possibly even worse than being conservative and giving a little bit less. So that temptation exists, and we've seen it over and over again. So the ability to de-escalate during the latter half of that first day, I think, is critical. Number two, increasingly we recognize the potential value of early infusion of colloids. So if the patient is en route to get more than 250 cc's per kilogram in that first 24 hours, just by extrapolating, by that 8th to 12th hour post-burn, we're going to add colloids, and we're going to aim to decrease our crystalloid dose. Now, what colloids you may have available varies. Traditionally, we used 5% albumin in normal saline as our colloid at a dose of 0.5 cc's per kilogram per 24 hours. Now, however, we're increasingly recognizing that there may be extra value in giving plasma. And you can give plasma at that same dose, 0.5 cc's per kilogram per percent burn, divided by 24 hours to give you an hourly rate. And the reason for doing that versus 5% albumin is the theoretical benefit of plasma in sealing the endothelial glycocalyx to decrease the rate of edema formation. I think that you'll see a trend towards earlier colloid use going forward. And in fact, there will be a multi-center randomized controlled trial with exception from informed consent being conducted by the Lights Network to address that issue of plasma versus not for early burn shock resuscitation. And so that's really the key. The key element there in avoiding over resuscitation is situational awareness, number one, and number two, consideration of resuscitation adjuncts, of which number one is going to be the possibility of early colloid.
Lee, thank you for that really insightful review of burn resuscitation and not only almost a historical component with the colloids, with the albumin, but certainly futuristic looking with the use of plasma and the endotheliopathy. And I think that's really wonderful stuff. So, other than fluid resuscitation, what are the other components during the initial phase of burn care do you think are important for the general surgeon who's deploying to have situational awareness about?
Absolutely. And so in my mind, I've got a checklist of issues that sort of come from difficult experiences, right, as to what can go wrong during that first 24 to 48 hours. And we mentioned over and under resuscitation. Certainly, the first thing that comes to mind in a patient with a big burn or in a patient who has possibly been exposed to inhalation of smoke or other toxic fumes is airway management. So some patients have symptomatic inhalation injury, and it's pretty easy to detect those. They may be stridorous, for example. They may have respiratory distress. We're going to intubate a lot of those patients, and we don't want to wait until they lose their airway. Loss of an airway in a patient with laryngeal edema from inhalation injury is a calamity that's very difficult to recover from. So airway management, bearing in mind that not everybody needs to be intubated, and we do receive a lot of patients from referring hospitals with some minor facial burns, for example, prophylactically intubated, probably not necessary. On the other hand, in the deployed environment, you have to think if I'm putting the patient on an aircraft for a prolonged transport over land or over the water, do I want to risk losing that airway en route? So there's a judgment call when that prolonged transport comes into play. So airway management. The second thing is, what about extremity perfusion? People with circumferential burns of the extremities, particularly deep burns, they're going to be at risk for limb ischemia. I call that eschar syndrome of the extremities to distinguish it from the true intramuscular compartment syndrome that we might see in ischemia reperfusion injury or vascular injury and repair or blunt trauma, fractures, bleeding into fractures. Eschar syndrome from burns is different because the treatment is different, right? So decreased Doppler blood flow in the presence of a swollen, circumferentially burned extremity is an indication for an escharotomy. And people should be aware or seek online guidance in how to do that. And then check for pulse restoration after the escharotomy and continue to monitor. The other thing to keep in mind there is that, just by elevating burned extremities above the level of the heart, you can really reduce the tremendous edema formation that can occur during burn shock and resuscitation. Another thing that can happen that we need to pay attention to during the first 24 hours is we need to plan to do wound care. A good example of how the deployed surgeon has to go beyond ABLS is we need to do good wound care by the 24-hour point. If we postpone wound care past that point, we're going to incur the risk of an invasive burn wound infection. We want to avoid that. Most people don't have experience debriding burn wounds effectively. but most surgeons know how to do a good job of prepping a patient in the OR. And we really need to be vigorous and aggressive in doing this. It usually requires IV narcotics, plus minus benzodiazepines. On the other hand, the other alternative is to do it in the operating room if there's space available to get good analgesia. Bearing in mind, you really don't want to induce general anesthesia in a hypotensive burn shock patient if you can avoid it. But anyway, I got to do good burn wound care by 24th hour, and I would put on an effective topical antimicrobial. In the deployed environment, that may depend on what you have available. It may be silver nylon dressing or some other silver dressing. It may be one of the traditional burn creams, either Silvadene or mafenide acetate sulfamylon. In any event, one of those effective topical antimicrobials should be applied before 24 hours. And by the way, most patients have relatively small wounds, sort of on average 80%, 75% have burns less than 20% of the total body surface area. And there you have a little leeway because your risk of invasive infection is a lot less. And for a superficial wound with of limited extent, sure, we'll apply bacitracin, Xeroform, and some Curlix gauze, and that patient will be good to go until they follow up as an outpatient. So all of this concern about, early wound care pertains especially to full thickness burns and those that are greater than 20% TBSA.
Thanks, Lee. I think that's a perfect lead in. I wanted to talk a little bit more about that specifics of wound care. So you had mentioned that identifying eschar is going to be really important when looking at those circumferential burns so that we can do an early escharotomy. And also that identifying full thickness burns are going to be really important so that we can get that patient to the operating room within the first 24 hours. So I have two follow-up questions for that. Can you describe for the person who's maybe never seen a burn patient with this extent of injury, how to differentiate what is eschar, what is superficial thickness, and what is full thickness burns? And then what do we do after 24 hours when evacuation is delayed?
Yeah, absolutely. So, a lot of this is visual. And if you look online at pictures of burns, you can see the range from first degree, just some erythema, second degree, where we've got some blistering, and then third degree, which is that sort of dull, charred, or pale, leathery appearing skin. So there's quite a range there. And one of the other points, though, is that it's for us surgeons, it's not just a visual appearance. Oftentimes, it's also the tactile aspect. If I touch the wound with a gloved finger, is the wound insensate or can the patient feel that? And if the patient can feel something painful, then it's probably not full thickness because full thickness wounds tend to be insensate. The other clue is that if the wound has capillary refill in it, it's probably not full thickness, it's probably partial thickness. But here's the other thing. We don't really need, in the beginning, to figure out what's truly full thickness third degree versus what's just deep partial thickness. And sometimes we only figure that out in the operating room. And so early estimation of burn depth is really not the critical issue, in my opinion. Probably the most important thing that we do is measure the burn size, the TBSA, as accurately as we can, because it affects stuff like resuscitation as requirements, the decision to transfer a patient or not. Then the other thing that really affects transfer decisions is, can this warfighter continue to do their job, or does he need to get out of the fight? And sometimes that's more of a functional assessment than it is a consideration of, well, what's the exact depth of this burn?
That was a great review. Let's switch our concern now to inhalation injury. In the burn world, we are concerned about supraglottic and subglottic inhalation injury. What should the general surgeon know about inhalation injury? And what are the key aspects? You touched a little bit about airway management, but how should that surgeon approach the patient where there's concern for inhalation injury?
Yeah, so like we were saying earlier, we don't want a patient with inhalation injury to lose the airway due to laryngeal edema or injury of the upper airway, generally speaking. And over the course of the first hours, even within the first hour post injury, a patient may lose the airway due to progressive edema of the upper airway. We need to have a plan in place to deal with the patient who is en route to lose their airway from inhalation injury, whether that's a quick decision to go to a surgical airway in some cases or some other advanced airway management techniques. So what I'm trying to communicate here is that these patients can be very difficult to manage in terms of intubation. And as a result, people tend to be rather liberal with early intubation in burn patients, even at the risk of sometimes over intubating. Having said that, once we secure a definitive airway in one of these patients, they are still at risk for obstructing the airway due to buildup of mucus debris and fibrinous exudate, causing plugging of the endotracheal tube. That's one possibility. The other possibility is dislodgement of the endotracheal tube because of inability to properly secure the tube to the patient's head. Both of these are potentially difficult scenarios to manage, and therefore we want to pay attention to maintaining endotracheal tube patency through frequent pulmonary toilet, and number two, to securing that endotracheal tube successfully to the patient's body using something like umbilical tape ties around the neck. And finally, we need to be cognizant of the potential impact of inhalation injury on ventilation and oxygenation. And one of the things that we found to be very useful in terms of ventilator management in these patients is inhaled heparin, which serves to prevent the formation of obstructing clots and casts within the airways of these patients over a period of hours to days.
Thanks for that review. I'd like to transition a little bit now to something that's more focused on what's going to happen in the next conflict. So we see that during the time in Iraq and Afghanistan, our military surgeons encountered relatively few burn patients, and evacuation to experts like you was available. When we think about the next conflict, some planners are predicting that it may be quite different, where we're seeing burn injury numbers that rival what was seen in World War II. And we may be relying on non-specialists to be managing patients for up to 72 hours. So how do you envision that those scenarios may change either burn triage or our approach to how we care for patients downrange?
Well, absolutely. Even during OIF and OEF, I think there's over 4,000 burn patients in the DODTR. So there are burn patients even in the event of another regional conflict like OIF or OEF. We need, as military surgeons, to be prepared to take care of burn patients. We think that about 5 to 10% of casualties on the battlefield will have a component of burns. Often, by the way, in combination with other injuries, which makes military burn and trauma care a little different from civilian care. In the civilian world during peacetime, we don't see combined burns and trauma all that often. Sure, an occasional high-speed motor vehicle crash with fire, jumps out of a burning building, that type of thing. They're kind of unusual, actually. So what about large-scale combat operations, or LSCO? So if we continue to predict that 5 to 10% of combat casualties could have a component of burns, and if we say there's going to be 1,000 casualties a day for a couple of weeks or a month, then we can assume that we may have 50 to 100 burn casualties per day in a theater of operations, like the Indo-PACOM. Now, this number needs to be placed up against the total burn bed capacity in the United States. which is approximately, sort of as an order of magnitude, about 500 open beds. What that means is that over the course of 2 weeks, we could easily fill up all the available burn beds in the United States with burn combat casualties. And that's assuming we could distribute these people to one of 70 or 80 burn centers, if we could figure that distribution problem out. And we can also assume that with 1,000 casualties a day, like you say, we're going to have a problem with a strategic aeromedical evacuation. And therefore, less experienced people, right down to combat medics, are going to have to take care of these patients for a prolonged period of time, which is a very challenging situation. It's challenging from a supply and equipment standpoint, and challenging from an expertise standpoint. From a supply standpoint, if we take one casualty and give them 20 liters of lactated ringers for a, moderately big resuscitation, who's going to carry that lactated ringers around on the battlefield? And we don't have a good solution to that problem yet. Who's going to carry the burn dressings that we need? So we think there are substantial challenges associated with burn care during a prolonged field care scenario. That leads us to the question of triage. Triage is normal during wartime. We did triage in the Combat Support Hospital in Baghdad for host national patients with burns. We did triage, and therefore we need to know how to do triage as surgeons who may deploy. And it's not just a LISCO problem. Like I said, it was an OIF problem, it was an OEF problem. So if you take the burn size, the TBSA, and add the patient's age, we get a number. And we call that number the Beau Index, spelled B-A-U-X, a French author. So at a Beau Index score of 100, in the United States of America or Western Europe nowadays, you have about a 50-50 chance of making it. And therefore, if your Beau Index is greater than 100, your chances start to go down the higher it goes. And of course, if you have smoke inhalation injury, if you have other trauma, mechanical trauma, that will add to your predicted mortality. So therefore, if I take my Beau Index and I say I can only take care of a certain percentage of these patients, then I'm going to consider Beau Index in my, if you will, calculation. And for starters, I'm probably not going to resuscitate people whose Beau Index is greater than 100, potentially, in a triage scenario. But I cannot assume, right? I can't go into this assuming that I can disregard how to take care of patients with larger burns, because I may find myself with a few patients, and I'll need to know how to take care of them. So what I'm arguing for is we cannot simply revert to a strategy of pessimism, right? And we can't just base our preparations on the assumption that we will have an overwhelming number of casualties and that therefore we don't have to worry about how to take care of them. Because we will have burn survivors, and we will have patients who are stable for evacuation. And so we need to identify who those people are through triage, and then we need to do our best to take care of them.
Lee, thank you for those comments. It's erudite, it's insightful, and certainly provocative, and maybe a little bit concerning.
Absolutely.
A lot for us to think about. And I really enjoyed this conversation. What is the one thing that you wish every deploying surgeon understood about managing burns on the battlefield?
Well, that's that's a difficult question to answer, but we are surgeons, and we're members of a team. And so really, I'm going to answer that question in a manner which you might not have anticipated. And it's based on my experience in Baghdad, during 2 deployments. And by the way, we provided definitive burn care in Baghdad. Skin grafting, excision, rehab, nutrition, you name it, for host nationals. But the key technology that we applied and the key sort of set of knowledge, skills, abilities, right, that I felt was critical in the deployed environment was how to operate, how to form and operate as a team. Because everything we do here in the burn center in the United States or in other burn centers across the country is all based on teamwork. And sometimes we take that for granted. But you cannot do this type of care as a lone ranger individual for very long. You just can't be effective. And if you don't have a team, and if you don't have people who have prior burn experience, you still need to build a team, learn the stuff, do the research, and commit to excellence in this type of trauma care.
Thank you, Dr. Cancio. Your expertise and your commitment to advancing military burn care is much appreciated. And your insights here are going to help ensure that our teams are well prepared for what lies ahead on any battlefield to come.
Thank you. It's a pleasure.
Stay tuned for our next episode, and until then, stay ready.
Thank you for tuning into this episode of Frontline Surgery. We hope today's discussion has provided valuable insights into military trauma care.
Be sure to join us next time for more expert perspectives and battlefield-ready knowledge. Until then, stay ready.